theme of our overall policy summit is the midpoint in the decade of the kidney in reprioritizing patients across policy, regulatory, and payment decisions. And that's why I'm very pleased that our next panel will start to talk about things about protecting kidney patients and organ donor health, the policy opportunities that are available in 2025. And we're joined by a very distinguished group of individuals who have committed themselves professionally and personally to efforts that are a like cause with AAKP. First, we have Ray Downs. She's a co-founder and partner at Tarplin Downs and Young, LLC. She's a policy representative for the Partnership to Improve Patient Care, PIPSI, which we're a longstanding member of. She has background in the executive branch as a principal deputy assistant secretary for legislation at HHS, and also in the U.S. Senate as a senior staff person. Ray will go ahead and start talking about the issue of quality adjusted life years and their impact on innovation in patients. Ray, why don't you go right ahead?
Thank you so much, Paul. Can everyone hear me okay? Yeah, okay, wonderful. First of all, what an esteemed panel. I'm so grateful to be included. So thank you very much for the invitation to participate. As you said, Paul, this is and Christian's presentation was fantastic. What a great tee-off for us to discuss, here on the ground, real-time action in Washington relative to the strength and the power that voters bring to the process. So we're very grateful for the partnership with the folks who advocate on behalf of the kidney community back home. We couldn't do this here in Washington without all the work that happens on the ground back home. In Washington on the ground, maybe that's a good place to start, Paul, in terms of where issues like QALYs and access to innovation stand today. There has been a long-standing effort by this community and like-minded communities to really create an environment of both support and urgency to advance forward better protections and greater access and ultimately greater quality of care and tools and treatments for communities that are dependent on the healthcare system and innovation in the healthcare system. Quality adjusted life years is a term of art that has been around for, I would say now, about 35 or 40 years from a U.S. public policy conversation, but has existed in other parts of the world for a much longer period of time. Its moment is here, thanks to the work that Paul and the community did now back in the early 90s. We have a marker out there that using QALYs, which are essentially a discriminatory metric, when it comes to accessing healthcare, but also when it comes to making decisions about the value of innovations for patients. That was something that was spearheaded by this community to make sure that there was essentially a barrier or prohibition on the use of QALYs in making decisions at the federal policy level, but also in the insurance realm. Now, as we fast forward to this moment in time, the issue of a QALY ban being more expansive and more deliberate and more vociferously put forward by Congress, this is the moment for that, for a couple of reasons. One, because innovation is upon us. We have had a bit of an innovation desert for this community, and we are now in a position to see real potential opportunities for improvements in innovation. But what we cannot have is things like QALY bans or similar discriminatory metrics used to prohibit our ability to create excitement and incentive and ultimately access to new innovation. This is a barrier that needs to be broken down further than it has been already, and now is the moment to do that. The other issue, obviously, is around access through payment mechanisms and limitations like the bundled payment arrangement that really creates, for lack of a better way to say it, a disincentive in investing in and providing access to innovation. So I think there are two opportunities that are very clear, very distilled for this community to be really an important part of advancing forward. And, despite a lot of activity and noise and candidly a lot of partisanship right now, there is opportunity to engage on a bipartisan basis with respect to addressing things like QALYs and making sure that payment mechanisms that limit or hinder access to innovation and care are readdressed. The Trump administration, which obviously has been in place now for about 6 or 7 months, while on the one hand, there has been a degree of disruption and uncertainty that has been brought to the table. On the other hand, that is always an opportunity for communities, back to Christian's point, that are organized and laser-like in their focus and their engagement to take advantage of opportunities. And we saw activity in the first Trump administration that Paul was quite focused on and quite successful at helping to lead, that we can pick up on and advance forward right now. So, and I know we'll get to the others on the panel, so I just want to lay a little bit of the groundwork that now is a moment of opportunity. we have at least two, if not more, specific things we can focus on as a community that we can partner with groups like PIPSI and the broad group of additional stakeholders, including some of my fabulous panelists here, to really make progress on broadening the quality band and addressing some of the limitations on the bundled payment system. And sort of the mic drop moment is we actually had legislation introduced earlier this week to extend the ban on qualities. Kat Kamek from Florida, who was actually a former Energy and Commerce Committee staffer, now a representative, is leading the charge and picking up the gauntlet, which we're very grateful for after tremendous leadership from Kathy McMorris-Rogers before she retired at the end of last Congress. So happy to take more questions, but just wanted to sort of put that level set out there as we begin the discussion today.
Thank you very much, Ray. And let me come to you and ask you a question. I think that really kind of boils it down for patients who may be watching and the caregivers that they have with them. And that's this. Quality adjusted life years has been used in Europe and in other countries for a very long time. From a patient perspective, sitting in a chair, can you break it down in the most simpler terms? If a government official is using quality adjusted life years and somebody has multiple conditions, kidney disease and heart disease, what is the essential judgment that that government official is making about that person and their access to a potential life-saving therapy?
It's an excellent question, Paul. And really what happens is these are metrics, they're measurements that essentially place a differential value on a person's life. The healthier you are, the higher the value that they place on your life, and most importantly, the higher the value they place on making an investment in a treatment or care that you might need. If you are a person living with lifelong chronic or multiple conditions, as Paul said, the score, the value that is placed on your life and the potential for treatments, including innovations in the future, is going to be less. And that's just not okay. And as a country, we have rejected the notion of those sorts of metrics that pick winners and losers and create tremendous access barriers, as we have seen in other countries, particularly relative to new innovation. So that is the conversation that as we at a larger public policy basis, begin to talk about access issues, begin to explore, where are we making investments in new innovation, particularly for patient communities who have had very limited innovation for a number of years. This notion of, are we going to measure the value of a person's life and the potential treatment through this discriminatory metric, a quality or a similar measure, or are we going to set those aside, ban the use of those, and instead really look at the true value? Everyone is created equally. Everyone's value proposition from a healthcare and a treatment perspective should be equal, and that is what we want people using as a metric for measuring whether or not they should support innovation and access.
Thank you very much, Ray. You actually just captured, in essence, what all kidney patients go through. Because if you have kidney disease, chances are you have other conditions like heart, metabolic syndromes, and other things like that. I very much appreciate it. America has a proud tradition, and we intend to fight to keep it that way.